Hi, good afternoon. Thanks for being here both in person and over Zoom. This month, we have an exciting presentation from Dr. Trisha Chakrabarty, who is an assistant professor at the Department of Psychiatry and a consulting psychiatrist with the Mood Disorders Center for Excellence at the UBC Hospital. And she also recently joined the Matrix and Cluster Executive Committee. So she's been helping me organize these monthly rounds. But this time we get to hear about some of her work, and her presentation is titled Mind and Mood, Innovative Methods for Understanding and Treating Cognitive Dysfunction. So without further ado, please join me in welcoming Trisha.
Hi, everyone. Thanks for joining. I'm really happy to present a bit on the work that our group has been doing. So as Lily mentioned, I am a clinician. I work at the UBC Mood Disorders Center, just one floor down, where we primarily see people with complex, either major depressive disorder or bipolar disorder. And an area of clinical interest, and certainly my area of research interest, is cognitive functioning within mood disorders. Sorry, I should have checked. Can everyone over Zoom hear me and see the slides?
Yeah, sounds
Okay,
good.
perfect. Oh, hi, Ray. Okay. So these are my disclosures. Grant funding received. Most of this grant funding is related to a cognitive remediation intervention that we're developing that I'll talk about towards the end of the talk. And my objectives for this talk are hopefully for you to come away with a better understanding of the nature and magnitude of cognitive deficits in mood disorders, encompassing major depressive and bipolar disorders, what the functional implications of those deficits are, an understanding of the heterogeneity or the variability in cognitive functioning within mood disorders, and what are some potential emerging treatments for cognitive dysfunction in this patient population. So recognizing that this is a translational audience, I do structure this talk as a clinical conversation, a conversation between a clinician and a patient. And the reason I do that is because I don't really have the nice translational medical story to tell, which is where we have an understanding and an accurate and standardized means of assessing your symptoms once you complain about them. We have a means, an easy to access means of getting you a diagnosis, and then we can offer you a plethora of treatments and keep monitoring your treatments until your symptoms are resolved. When it comes to cognitive functioning and mood disorders, we're not there yet. But what I think we can do with the research and the knowledge that we have to date is we can share evidence-based information about cognitive dysfunction in mood disorders to this patient population. We know that the vast majority of individuals with a mood disorder at some point in their illness course will at least perceive themselves to be suffering from some form of cognitive dysfunction. So clinically, these are questions we get really commonly. And this is partially from some qualitative work we did in developing this intervention that I'm going to talk about in the second half. You just need to talk to anyone who's experienced depression, is living with bipolar disorder, to know how common and how impairing these cognitive issues can be. So I do think that where we are right now, we can at least provide some evidence-based and accurate information about cognitive dysfunction in mood disorders, even if we're not yet at that nice translational arc where we can diagnose, treat, monitor, and resolve the symptoms. So the first question we certainly see or encounter frequently is something along the lines of, I've been having problems with my concentration and memory, and these are affecting me at work, at school, or at home. Could they be related to my depression or my bipolar disorder? So mood disorders are conceptualized as disorders of affect, disorders of emotion. However, we know that these disorders are also associated with a variety of cognitive symptoms, including things such as problems with concentration, difficulties with memory, problems with organization and planning, and slow thinking. So just taking a step back, what is cognition? And probably to this crowd, I don't need to go into it in too much detail. But one distinction that I would like to make, because I think it's important for this talk, is a distinction between hot cognitive processes and cold cognitive processes. So hot cognitive processes generally could be understood as cognitive processes that have an emotional component to it. So for example, if you are, standing up here giving a talk, it might be that I am selectively attending towards the one person who looks really disinterested while discounting all the people who seem engaged. It could be that after this talk, I selectively recall the one negative or equivocal comment while completely discounting and not recalling the positive feedback. So generally, when we're thinking about mood disorders, certainly depression, we often think about these hot cognitive abnormalities. We know that people with depression can have a tendency to selectively attend towards negative stimuli and have a bias towards recalling negative components of an event. And when we think about many of our psychological and behavioral interventions, such as cognitive behavioral therapy, that is what we are sort of targeting, these hot cognitive abnormalities. That's not what I'm going to be focusing on today. I'm going to be focusing on so-called cold cognition, or cognitive processes that are independent of an emotional influence. And that's not to suggest that these two types of processes don't interact, because they do. It's just they're not generally assessed in concert or jointly. So I'm going to be talking about studies and data that comes from assessments of cold cognitive domains. So that includes domains such as attention, which is the ability to focus, maintain, or shift attention; processing speed, which is the ability to rapidly perceive and or respond to stimuli; working memory, which is the temporary storage and manipulation of information; verbal learning and memory; visual learning and memory; and executive functioning. So the ability to plan, problem solve, and inhibit inappropriate responses. So in major depression, individuals who are in the midst of a depressive episode, so who are acutely depressed, demonstrate significant deficits in executive functioning, memory, attention, reaction time, with moderate to large effect sizes. So these are not minimal deficits that individuals experience. So this is from a meta-analysis that's 10 years old now, but the results have generally held up in subsequent meta-analyses. If you look at the black bars, those represent the effect sizes for differences in the magnitude of performance in these specific cognitive tests compared to a healthy population. And you can see, again, we're generally talking about moderate to large effect sizes across multiple domains. Now, the important thing is that these deficits remain detectable on a group level in individuals after they've remitted from their depressive episode. So when they no longer meet criteria for a major depressive episode, most, if not all of their other depressive symptoms seem to have resolved, we still detect at least small to moderate deficits, again, across multiple domains. So from the same meta-analyses, if you look at the gray bars, that represents the effect sizes of studies or individual participant data from individuals who are in remission from their depressive episode. In bipolar disorder, the magnitude of cognitive impairment is generally larger than what you see in major depressive disorder. Unsurprisingly, in manic or mixed states, you see large magnitude impairments across multiple domains. In depressed states, you see moderate to large impairments across multiple domains. But again, importantly, in euthymic states, when people have remitted and they no longer meet criteria for either a manic, hypomanic, or depressed episode, we can still detect moderate to large deficits in multiple domains. Now, why is this important? Cognitive functioning, even after controlling for overall symptom severity, appears to be independently associated with real-world functioning. So an individual's ability to function in social situations, in the workplace, academically, or at home. So this is data that we collected as part of the CanBind study, which is a multi-site study of individuals with major depression that were enrolled into this study for a standardized course of antidepressant treatment. And I'll talk a little bit more about CanBind in a little bit later. But at enrollment, we had approximately 200 individuals who were acutely depressed. And what you can see is that, unsurprisingly, overall symptom severity is negatively associated with work and school functioning. So the more severely depressed someone was, the worse they were functioning. That's not surprising. But after controlling for this, you still see a significant association between objectively measured cognitive functioning and their ability to function at work and school. Other studies have also shown that in individuals who are remitted, again, who do not meet criteria for major depressive episode, their executive functioning or persistent executive functioning deficits are significantly associated with their ability to function at work or at school. We see the same in bipolar disorder, that cognitive functioning is associated with psychosocial and occupational functioning in bipolar disorder. And again, this holds true even when you restrict to individuals who are not meeting criteria for a mood episode. And there is a longitudinal association such that cognitive functioning at baseline will predict people's functional, school, work, and social outcomes after 1 year. So going back to our fictional patient, the answer we can give to the question of, could these difficulties that I have been experiencing be related to my mood disorder, is that yes, they can be, because we know that mood disorders can be associated with problems with concentration, memory, problem solving, and multitasking, and that these problems can persist even after other mood symptoms improve, and that these difficulties can affect your ability to function at work, home, or school. So the follow-up question, at least I often get to that, is, okay, so you are saying that I must have some degree of cognitive difficulty. I have depression, I have bipolar disorder. Is it the case that I must then have some cognitive issues? So we know that on a group level, patients with mood disorders show cognitive impairment. But just as there is variability in cognitive functioning within a healthy or a non-clinical population, we also see that not all individuals with mood disorders are going to be equally impacted or show the same degree of cognitive difficulties. If you apply what are sort of traditional criteria for cognitive impairment, which is generally scoring 1 to 2 standard deviations below people of your same age, sex, and education level in one or two cognitive domains, we see that only in outpatients, at least, only about 30% of individuals will meet this criteria, and the remainder of patients will perform comparably to healthy participants. So who seems to be affected? In depression, it seems to be individuals who experience, unsurprisingly, more severe symptoms, a high number of episodes, so who have a highly recurrent course where they're experiencing frequent mood episodes, and also who have a later onset. So their first onset of symptoms after age 55 or 65, depending on the definition. And the people who are most at risk of experiencing persistent cognitive issues, even after their other depressive symptoms improve, seem to be, again, these individuals with late onset depression or a higher number of previous episodes, so highly recurrent illness. So one factor potentially affecting cognitive functioning in individuals with depression, which up until recently has been relatively understudied, is the impact of childhood trauma. So we know that trauma in the developmental periods results in chronic alterations in HPA axis activity, which subsequently impact aspects of brain structural and functional maturation. And it's been established that childhood maltreatment is associated with impaired cognitive functioning in adulthood, even when you look at individuals who do not suffer from a diagnosable form of psychopathology. So individuals who do not meet criteria for PTSD based on their previous traumatic experiences or for a mood disorder, for example. And we also know that individuals with depression are at much higher risk of having experienced childhood maltreatment than the general population, with approximately half of adult patients with MDD reporting a history of childhood maltreatment. So we looked at this potential association using data from the Canbine cohort. So again, we had approximately, we had more than 200 patients, but we had 180 of them who completed a fairly extensive structured interview assessing multiple different possible forms of childhood maltreatment, including emotional abuse, sexual abuse, physical abuse, and neglect. And what we found is that, very similar to what's been reported previously in the literature, about half of these 180 patients reported what we defined as a severe level of childhood maltreatment, versus 20% of our healthy participants. And what we found was that at enrollment, so again, all of these patients were in the midst of a depressive episode when they entered into the study, that it was the patients who reported a history of childhood maltreatment that scored significantly lower than healthy participants on objective measures of global cognition, memory, and processing speed. Whereas the half of patients who did not report a history of severe childhood maltreatment actually performed fairly comparably to healthy participants. And what we also found was in these patients, so as I mentioned, these patients received a total of a 16-week course of standardized antidepressant treatment, and they repeated cognitive testing at the end of this. So if we looked at the approximately 50% of patients who by the end of the antidepressant treatment course were in remission, so they no longer met criteria for a depressive episode, they were they had experienced successful treatment. It was the patients who reported a history of childhood maltreatment that showed persistent deficits in working memory and processing speed, despite the fact that their other depressive symptoms had essentially resolved. Whereas again, the MDD patients without that maltreatment history performed comparably to healthy participants. So what this told us is that childhood maltreatment is in fact a risk factor for cognitive dysfunction in individuals with depression in the acutely depressed state, but also importantly appears to be a risk factor for persistent cognitive deficits even after being successfully treated for depression. So another way to sort of look at heterogeneity in this group is to look at empirically based methods of clustering individuals based on their cognitive functioning. So as I mentioned, if you apply certain pre-specified criteria to define impairment, like if we say that we define cognitive impairment as being 1 to 2 standard deviations below a normative mean, that might not give you the most accurate picture of what the distribution and what different subgroups within that population actually look like. So there's been a lot of interest recently in using data-driven techniques, sometimes involving machine learning, to generate empirically based subgroups of individuals based on their cognitive functioning. What these models tend to find is that you have, within bipolar disorder and major depressive disorder, you tend to find a subgroup who is characterized by global and severe impairments. So severe impairments across pretty much all cognitive domains. But then you also have a subgroup who appears to display average to above average cognitive abilities, and possibly 1 to 2 intermediate subgroups with either an intermediate degree of impairment across multiple domains or impairment that's select to 1 or 2 domains and relatively normal functioning across other domains. And the reason this is potentially interesting is it indicates the presence of a cohort of patients who may benefit from more targeted intervention. Because there seems to be a substantial number of individuals with preserved cognitive functioning within this patient cohort. If we have a reliable method of identifying those with global and severe impairment, that can help us target our interventions to those who need it. So this is an example that was published just last year, actually. And they used data from an extremely large clinical trial that was run across multiple international sites of they ended up recruiting, I believe, over 1,000 individuals with depression and then randomized them to different forms of antidepressant treatment. The important thing was they tested cognitive functioning for almost all of their participants at enrollment. And they used a clustering method to try to delineate cognitive subgroups within this patient population. And what they found was a 2-model solution, which they termed biotype positive and biotype negative. So the biotype positive people group was approximately 25% of the cohort, and they showed substantial deficits across multiple domains. So deficits between 0.5 to 2 standard deviations below what would be expected across several cognitive domains, whereas this biotype negative showed fairly normal or performed as would be expected across all domains. But what was salient in this study was they found that it was the biotype positive people, so the people who showed this pronounced cognitive dysfunction at enrollment when they were acutely depressed, who showed limited or no improvement in their cognitive functioning with treatment, whereas the individuals who were fairly preserved to begin with showed some degree of improvement. They also had lower response and remission rates overall to antidepressant treatment. And in a subset of these individuals who completed a cognitive control task in the fMRI, it was these biotype positive individuals who showed poor recruitment of the dorsolateral prefrontal cortex, as opposed to the biotype negative people who showed fairly preserved recruitment of this region. So using data from the Kanbine cohort, and this is data that we're working on right now, we applied a different clustering algorithm than what was used in that previous study, but we got results that were not dissimilar. So here you can see the model that seemed to fit the data best is a 3-cluster solution. So the dotted purple lines are our healthy controls, are individuals who have no psychiatric history, no history of depression. Approximately 40% of our 200 person cohort with depression seem to have this high performing kind of profile that I mentioned before, where across all domains, they perform comparably to healthy controls, if not better in some domains. Then we have 30% who are sort of average performing. They perform not too differently than what you'd expect based on their age and sex, maybe a little bit lower than normal. But then we also have a third who are quite low performing, particularly in measures of attention and executive functioning, which again, if you look at the ISWAT-D study, they found particularly severe impairments in measures of executive functioning. What seems to be the case when we look at these individuals who form the low performing group with antidepressant treatment, they seem to have more persistent cognitive deficits than the other 2 groups. They have worse functional outcomes in terms of measures of psychosocial functioning. They do worse than the individuals in the other 2 groups. And similar to our previous study, there is indeed a higher prevalence of severe childhood maltreatment in this group. And then moving to bipolar disorder, we applied a similar sort of idea, again, a different kind of statistical approach to look at this issue of cognitive heterogeneity in the early phases of bipolar disorder. So we have a cohort of approximately 100 individuals who have just recovered from their first episode of mania. So they're generally young people, and again, just diagnosed with bipolar disorder. And what we found was, again, we have about a third that have this globally impaired pattern of deficits across multiple domains. About half of the cohort showed deficits in processing speed, but actually fairly preserved functioning performance across other domains. And we have about 15% who are quite high functioning and score, fairly well above average across multiple domains. And what was interesting was in our first look of in this data was the globally impaired subgroup showed a pattern of IQ and structural imaging characteristics that seemed to be suggestive of a unique neurodevelopmental course. So there are ways to measure someone's estimated premorbid IQ. So you can measure certain aspects of what is believed to be fairly crystallized intelligence that usually doesn't show decline until you're quite severely advanced in your disease. So that can give you a measure of what that person's intellectual functioning was prior to illness onset. And if we look at the change from the individual's premorbid to their current IQ, that can give you a very rough sort of proxy measure of how much of a decline from their estimated premorbid functioning they've experienced as a result, or not necessarily as a result, but during the time that they developed the disease. So what we found was that the globally impaired patients actually seem to have a similar premorbid IQ to the other two groups of patients, the selectively impaired and the high-performing group. But they had the steepest decline from their premorbid to their current IQ. So something was happening at the time, around the time of disease onset, that was negatively impacting their cognitive functioning, even though up until that point, at least based on this rough measure of premorbid intellectual functioning, they weren't showing a high degree of impairment. When we looked at it, again, a very gross measure of structural changes, we found that the globally impaired individuals had lower total white matter and higher total gray matter versus healthy participants. And if you look at a voxel-based analysis, there is this tiny little spot in the frontal cortex where individuals with global impairments showed higher gray matter. So sort of extending on these sort of indicators that maybe this globally impaired subgroup is showing some evidence of a unique neurodevelopmental course, we looked at a measure called brain age. So models have been developed, and I'm nervous talking about this in front of Brian because he's developed the biggest model, but correct me if I'm wrong. So models have been developed using large cohorts of typically developing individuals. And these can be used to estimate or to give an estimated age of your brain. And the difference between your estimated biological or brain age and your chronological age gives you a brain age gap. So if you are, if your brain age is lower than your chronological age, that's a sign of delayed aging in adults or perhaps delayed maturation in children and adolescents. Whereas a higher than expected brain age compared to your chronological age is an indicator of advanced aging. In cohorts with schizophrenia, for example, it's been fairly well replicated that cognitive dysfunction is associated with advanced brain age. Whereas the data in individuals with chronic bipolar disorder is a lot less clear. So within our early bipolar cohort, the mean brain age of the entire cohort was just slightly delayed, like -1. So that means on average, the brain age of this group was 1 year less than would be expected. However, if you break it down based on their cognitive performance, so if we look at our cognitive subgroups, it was the individuals with global impairment that showed far more pronounced delay in brain age, or far more pronounced lowering of their brain age compared to what you'd expect. Whereas individuals who are selectively impaired or high performing, their brain age wasn't significantly lower or higher than what you might expect given their chronological age. Mhm.
When you say lowering your brain age, is that meant to imply a deficit or an improvement?
Yeah, it's a good question. Because well, first of all, it could depend on what life stage you're at, right? Because if you're older, let's say your chronological age is 50, but your brain age, your estimated brain age is 45, that generally would be an indicator of health overall, cognitive health, physical health. However, if you are 15, your chronological age is 15 and your estimated brain age is 10, that would be a measure of some kind, or that would indicate potentially some kind of maturational delay.
On this graph here, you're in the 50 to 65.
Oh, sorry, this is just like a schematic. Our early,
When you look here,
yeah.
what is the relative age of the group?
Yeah, so in this, because these were first episode patients, they were all between the ages of 15 to 35. The mean age was approximately like 22. So they're a young cohort, again, because they've just recently had illness onset.
On that cusp being
Yeah.
difficult to attribute whether
Yeah.
it's a maturational issue or improved health because your brain is aging.
Yes, yeah. I mean, our data would indicate that there's some kind of it might be best conceptualized as a maturational delay because again, it's the individual with pronounced cognitive dysfunction that seem to show that have the lowest brain age. But you're right, they are on that cusp where, you know, it's hard to know in what direction the association is with health or with pathology.
Sorry.
Mhm. Yeah, so for this data, it was just based on structural MRI.
Oh.
Yeah, but you can measure brain age with functional MRI data. There are measures of biological aging that are based on, yeah, exactly as you said, like epigenetic, peripheral inflammatory markers. This data is just based on structural MRI. So to the question, or back to the question of our fictional patient, is my mood disorder causing me cognitive problems? Not necessarily. Not everyone with a mood disorder experiences cognitive difficulties. And if anything, many have normal, if not, you know, higher than might be expected cognitive functioning. The risk factors that may be an indicator of cognitive dysfunction include high number of previous mood episodes, age of onset after 55, age of onset of mood symptoms, particularly with depression after age 55, a substance use disorder, experiences of childhood trauma. And we may be able to, in the future, we may be able to detect a subgroup with pronounced impairment characterized by poor functional outcomes and distinct neurobiological features who may benefit from more intensive treatment. So I'm actually just looking at time. I'm just going to go to treatment. So the $1,000,000 question, if I do have cognitive problems, how can I treat them? So spoiler alert is essentially there are no great treatments specifically for cognitive dysfunction in mood disorders. So in the latest iteration of our of the CANMAT guidelines, which are the foremost treatment guidelines that are used by clinicians in Canada and internationally for depression, they did delineate some antidepressants for major depressive disorder, which may have a special benefit for cognitive symptoms. One of them being this relatively new antidepressant called vortioxetine. And if you look at the data, antidepressant treatment can have a positive effect on cognition overall, but the magnitude of that effect appears to be quite small. And again, even though vortioxetine, this, purportedly pro-cognitive antidepressant that I mentioned, had the largest pooled effect size compared to other antidepressants, again, we're still talking about a relatively small effect. So sorry, I'm just looking at time, and I think I will. So what we kind of are focused on are on more behaviorally based strategies for improving cognition in mood disorders. And one such strategy is called cognitive remediation. So cognitive remediation is an intervention which is meant to target specific cognitive deficits, usually through the combination of drill and practice type games, with training on implementing compensatory strategies in your life. So you've probably come across the kind of, the luminosity type programs where you play these cognitive games that get progressively more difficult as your performance improves. But these are standardized protocols that use those types of games, but in a very strategic and guided way, with the aim of you being able to take the skills that you develop and that you are trained on and actually apply them to your real life. Cognitive remediation has actually shown quite robust evidence for improving cognitive and functional outcomes in psychotic disorders, so in schizophrenia. It's now considered standard of care to provide cognitive remediation for individuals with schizophrenia. And there is a relatively recent Vancouver Coastal Health-wide program to provide cognitive remediation for individuals with schizophrenia. And in depression, it shows some promise. So what the meta-analyses show is that cognitive remediation can result in what appear to be moderate size improvements in measures of global cognition, verbal memory, processing speed, working memory, and executive functioning. But where the difficulty comes is it's not clear the degree to which these improvements actually translate into real-world functional outcomes. So some studies have shown that cognitive remediation results in small to moderate effects on daily psychosocial functioning, where others have not shown that improvement in real-world functioning, even though they do show that there is an improvement in cognitive performance across multiple domains. The same seems to be true for bipolar disorder. There are fewer controlled trials of cognitive remediation in bipolar disorder. And some RCTs, some randomized controlled trials do show improvements in various cognitive domains and psychosocial functioning, but again, others find really minimal improvements with no effect on psychosocial functioning. So with cognitive remediation in general, but in mood disorders specifically, what we're really looking to do is find ways to maximize the transfer of the skills you learn through cognitive remediation into real world improvements. And it seems to be that the programs that incorporate these sort of, the sort of fun cognitive games with strategy-based approaches that help the person apply those skills to the real world seem to result in the greatest improvements. And that's where we sort of developed an interest in virtual reality and whether that could improve the transfer of cognitive remediation skills into the real world. So in brain disorders in general, there have been a number of virtual reality cognitive remediation programs that have been developed and actually show pretty promising results in disorders such as stroke, mild cognitive impairment, and Alzheimer's disease in terms of improving cognitive performance and as well as aspects of psychosocial functioning. And there have been a number of studies in schizophrenia of virtual reality cognitive remediation, which again show fairly robust improvements in aspects of cognition and functioning. So these are just some example of the types of VR exercises that are provided through these VR programs. So there's one where, like, for example, a sustained attention task where you're walking through a park and you have to pick flowers of a certain color or shape or size. Quite a few of the programs focus on aspects of social cognition, so recreating job interviews or just, you know, conversations. Many of them have a sort of vocational focus, so they could focus on, for example, working at a cashier, helping you develop those skills, help you with day-to-day sort of things like going through a grocery store. But for depression, there were very, very few studies, and they were very small, not and not with the most rigorous methodology. These studies do seem to indicate that you can have good cognitive outcomes with virtual reality interventions. But again, because of the limitations of the studies themselves, it's hard to say. So what we have been doing is we've partnered with the National Research Council of Canada to develop a cognitive care platform that targets multiple cognitive domains that are affected across many psychiatric disorders. And we have been working to try to tailor this intervention to the types of deficits and the concerns that are seen in individuals with depression. So just as an example of some of the tasks that are in Be Well, there's a task of sustained attention where you walk through a setting and you have to pick up eggs or different objects by sustaining your gaze on these objects. There's a task, a multitasking task where you have two tablets and you have to follow 2 recipes at the same time, going between recipes. There's a memory task where you're presented with a sequence of objects, the curtain falls and you have to recreate it. And then there's the universally beloved whack-a-mole, where you have moles of different colors coming up and you have to hit the mole of a certain color with the correct hammer. So what we did is we undertook a co-design process. So we presented clinicians who work with individuals with depression, as well as persons with lived experience of depression with the Be Well prototype. And we had a sort of semi-structured interview where we asked for their feedback, what they thought of the program, and what sort of changes they would like to see implemented to make it more feasible to their life. So clinicians, first of all, indicated that overall they had limited personal and clinical experience with VR. And they were aware of some of the VR applications for treating anxiety and psychotic disorders, but not so much what the applications could be for depression. However, they did see a promise for VR in general to act as an adjunct to current clinical care. And they really wanted to see us emulate real-world settings in this intervention, as well as incorporate a motivation and reward structure. And from persons with lived experience, again, they said that they had limited personal and clinical experience with VR, but they were quite interested in trying these interventions with some clinician guidance in place. They named accessibility and cost as major barriers, but they also said that they wanted to see more real-world settings emulated as opposed to really gamified settings. And they really wanted to see multisensory stimuli and multi-domain tasks. Let's see if this works. So this is an example of the lab task.
You have just started your first recipe. Look at the tablet and pour the correct ingredient when the timer reaches the colored section. Good.
So as you progress through this task, the recipes
It is
become
too late
more
for this ingredient.
complex and more difficult to follow. So the recipe is on the tablet here. So you have to put, when the tablet indicates, you have to put the appropriate color into the appropriate vat for the specified amount of time. And
Good.
I know what you're thinking, that in terms of this emulating a real world setting, rarely are you in space following two different recipes. But it was interesting because we tried to put this into a more naturalistic setting, and people indicated that they actually did prefer the more gamified virtual setting. But so where we saw opportunity to really capitalize on the capabilities of VR while also addressing some real world challenges was in the addition of this, we call her the supervisor. So going back to, I know earlier I said I wasn't going to focus so much on hot cognition, but we know that individuals with depression can have a very strong response to any perceived negative feedback, which can affect their actual performance on tasks. So what the supervisor does is as you progress through the program, she does give you, she does point out when you make a mistake. She's like, you poured that too early, or you poured in the wrong color. And as you progress, the amount of positive feedback slowly becomes less, and the amount of sort of not mean, but kind of terse negative feedback goes up. So that was one way that we thought that we could sort of recreate a real world challenge that individuals with depression experience, but still keep it fun and engaging. But it's not something that you can necessarily do in sort of traditional computerized cognitive training programs. So going back to our question of our fictional patient, if I do have cognitive problems, how can I treat them? We can say that some medications may have modest pro-cognitive effects, and there may be some benefit to cognitive remediation. But the most important thing we can really advocate right now, based on where the evidence is maintaining those things that we know are important for general wellness, such as diet, exercise, socialization, and help support individuals in advocating for compensatory strategies at their work or their school. So in conclusion, cognitive deficits do affect a significant subset of individuals with mood disorders, although not everybody. And they are an important contributor to psychosocial disability, and they can persist even in remission. And we're still needing to develop effective and reliable treatments specifically for these deficits. With cognitive remediation specifically being a promising treatment strategy, but the degree of real world improvement remaining unclear. So that was it. Were there any questions? I do, yes. Mhm.
It's not as like real world, it's just on screen, like.
Yeah, so in general, with existing computerized cognitive remediation programs, they the sort of largest providers like such as Happy Neuron Pro, they do offer at home sort of programs that you can do at home and then share the results with your clinician, for example, or have your clinician sort of guide you through and answer questions, but you work on the exercises at your own time. And they also provide like workbooks that can help the person independently sort of develop strategies to what are called bridging strategies, like strategies to apply those skills to their real life. For our program, we are actually looking at developing a home-based version of this. So this would be using headsets that don't need to be hooked into a computer. They're called standalone headsets. So you just put on the headset and then through the interface you see on the headset, you can start the program. So we're looking at developing that as a potential alternative to a version where they come on site and do the program.
So in our lab, we use cognitive remediation. It's like 6 and our schedule is for 16 weeks.
Mhm.
What's the schedule?
Yeah, so right now we're doing a pilot RCT, and we are doing 8 weeks, 2 sessions a week, so 16 sessions total. And the results of the pilot will help inform whether or not we think that we should go longer or shorter.
In your pilot study that with, because I know with communication with individuals who have were affected with symptoms more severely, because it requires a lot of motivation.
Mhm.
It's not as effective with the VR version. Have you noticed a difference in terms of engaged?
Yeah, so our pilot study with clinical individuals is too early for us to tell. We did a preliminary study in non-clinical individuals, so individuals who didn't necessarily have a diagnosis of depression. And we presented them with a computerized version of these tasks versus the immersive VR. And they indicated that they preferred the VR. They felt that it was more engaging and they felt more motivated. But whether that translates to better retention in a clinical population, that's what we're trying to see. Yeah.
Have you seen evidence of TMS and cognitive mediation having any complementary impact?
With with
TMS and
for oh yeah, so that's a great question. There have in fact been some studies published both with transcranial direct current stimulation and cognitive remediation, as well as RTMS plus cognitive remediation, which seem to indicate that there is some kind of synergistic effect of both interventions compared to either alone. These are really quite small studies.
ketamine.
That's a good question. As far as I'm aware, there aren't any, I'm not aware of any studies that have looked at the long-term effects. Yeah, there are some studies that in the short term, after the dissociative effects have come off, obviously, show some improvements in some aspects of cognition, but I'm not aware of any that have shown or have looked at sustained effects. I unfortunately do have to go. Sorry, I have to do the daycare run, but I'm happy to if there are any other questions, I'm happy to answer over email, or I'll also be at these rounds, as Lily mentioned, so happy to talk to anyone. So, but thank you very much for your attention.